I also posted on Blackboard for the exam. Okay.
I'm just happy to be back in town. So cool.
Oh, you did. I saw you after rehearsal today.
Huh?
Did you watch
You know that you have in other classes, you know that you're reading for the exam is pretty much a good thing to do. If you can address all those points on the exam, there's no reason why you wouldn't do well on the exam, right? Because there's a lot of information, there's a lot of different professors talking to you, at you, and so I know to kind of narrow and tailor your study and exam is important, with all these essays and what else you're getting. Okay, now. All right, so this is excellent. Does anyone have class in here, other than that? Was she able to get the images up? Oh, there you go. Okay. All right. So I'm gonna stay there.
Is it on?
Comment.
Is it on?
Yeah.
How about if I yell loud?
Yeah,
I don't think the microphone's making a difference, to be honest.
Yeah, I feel like I'm.
But if you yell, that
Want
works.
to come down a little bit? I just don't, I feel like I'm in a
Speak
bubble
loudly.
chamber.
Yeah.
If there had to be an important chapter in this textbook, it would have to be chapter 3 because it talks about growth and development. And we know that growth and development in kids is not just physically the way they grow up and get big and tall, but they grow in physiologic ways. They also grow in developmental ways. And so Erickson talks about his stages of growth. Freud talks about their stages of growth. And then to a lesser extent, there are people that are trained in the cognitive growth of Piaget. And so these are the main authors in this chapter. I tend to focus a lot on Erickson because I think that's the one that, number one, I grew up on. Number two, tends to come back and back and back again. You're not going to be taking care of kids and saying, oh, look at that, that's this stage of development. But it does come back when Erickson talks about different stages of social development, that you will see that in children that may or may not be able to reach those stages. And he talks about it as kind of a punitive thing. In other words, if you can't get out of initiative versus guilt, then you're not going to be able to move on. Because you still need the building stones from initiative versus guilt to go to the next stage. So I think that those things are important when you see kids in who are chronically ill. For those of you on heart, renal, kidney, for example, a lot of these children have chronic illnesses that doesn't allow them to grow socially because they're limited. They've got a medical regime that doesn't allow them to do that. Some kids you might have already seen in other clinical settings where they have neurologic devastation. So you might be stuck in autonomy, there's autonomy versus guilt, but just being able to do their own life skills physically will not allow them to grow on. So, I mean, it really does come back. We talk about teenagers and adolescents, and Erickson, he talks a lot about, independence, and I like to think of adolescence as that age where you go from a very me cycle to me and what am I doing in this world kind of cycle. And people have to go through stages in order to accomplish that development. So I think when you meld that development in terms of new skills and how kids acquire them and what we look for. And in terms of, it's not just walk, run, walk, run, skip, whatever, and hop, but it's putting that together with knowing where they are and what kinds of interactions they're having. And then the maturation part of things is possibly genetically influenced, but not to a certain extent. I mean, obviously, if you have kids who have genetic propensities toward dysphasic lobes of their brain, okay, well, then that's going to impact their growth and development. So, but, it's not all just genetically driven. So we see a lot of people who say, oh, you act a lot like your mom, or oh, you act a lot like your dad. No, it's not. That's a little more learned behavior mixed in with maybe some genetics. So again, you got to think about all these things when you're looking at kids. Growth and development gets influenced by these factors. Obviously, people would say that heredity and the environment are going to depict how a kid develops. People in Ecuador are going to develop a lot different than people in Asia because you have an environment impacting them and temperature. So those of us in the United States are going to have different opportunities and chances for our development that maybe they wouldn't have in a third world country in Africa. Okay, so environment does have a lot to do with it. Hereditary kind of comes in and mixes in. When we talk about environment, it also can contribute to things that would hinder development. So, for example, what's the biggest health crisis right now that we're facing? Zika, okay? And what is the big concern as far as the impact on kids? Everybody knows? Yes.
Causes like microcephaly, so they
Yeah.
have small heads.
Small heads mean small brains. Small brains don't grow, they don't develop, right? So this is a major impact on children growing up. The other problem is that we know that the virus in the microcephaly is not picked up until the third trimester. So you could have a normal pregnancy and you could end up bearing a child with microcephaly. Now, you don't have to have the Zika virus, you can have other, there are other things that can impact it, but the point is that that is something that impacts kids and will impact their growth and development for their lifetime. So we also look at things like in the environment or hereditary, focusing more on hereditary, things that children are born with. So muscular dystrophy, for example, affects boys more than girls. Scoliosis, curvature of the spine. Girls are more likely to develop scoliosis than boys. We don't see boys with scoliosis, but if children are neurologically devastated, we will see scoliosis in any, either sex of a child. So again, we try to look at trends and what to expect. Other things that impact the environment, which I think are really important, is if a child grows up in a smoke environment and has maybe a hereditary propensity toward asthma. So that's why we ask questions like, are there any smokers in the house when we have kids who show up with bad coughs or wheezing or whatever? Secondary smoke is an important thing to think about. So nicotine and smoking, obviously alcohol abuse, and other things that people don't think about but does affect development is violence in the home or in the world the child is in. You can't tell me that in the Middle East, where children have grown up with violence all their life, that that's not going to impact how they develop, right? So I think that environment is a very powerful factor that will ultimately impact how a child develops. We talk about nutrition, and all you can think about is third world countries. George Clooney's out there saying poor nutrition, poor development, and it's true. It could affect their physical mobility through bones and lack of calcium. It could affect at a very young age, and we focus a lot in the first year of life is on nutrition. Because we know that nutrition doesn't get to the cells, then the brain is not going to grow. So we see that. How? We see that in delayed developmental growth. And so we look for children for the first year of life to make massive gains in their development based on the fact that they're getting adequate nutrition and they're being health screened appropriately for diseases that can be prevented in the child that can cause massive developmental and growth problems. Back to the environment and what children grow up in, the people in China have big concerns about their kids and growing up in the smog and the air pollution, because that leads to not just delayed growth and development, but possibly tetragenic or cancerous kinds of situations. So, when we talk about stages of development, different people break it down different ways. I like to think of it as infancy, toddlerhood, preschoolhood, school-age kids, and then adolescence. The book uses a different way of approaching it, but we both cover the same kinds of things. I actually do that because Erickson tends to do infancy, toddlerhood, preschool, and school-age adolescence, but it doesn't really matter. And then there is a new stage of development that people talk about. It's called the emerging adult. Those of you in your age group up to age 26. And we use these informally, but actually pretty formally, to do different kinds of initiatives. One of the ones where the emerging adult was used as a 21 to 26 is what? You all get to, when you graduate, do what now? Because of an act that was put into place by President Obama. What it is? Huh? Because of the Affordable Care Act, because it used the developmental level of the emerging adult, 21 to 26, as a crucial period of time. And so, they use them interchangeably in society, so it's something that it kind of goes without saying. So, I mentioned this, I know, about a month ago, that kids tend to grow both up and down and out, so we call that cephalocaudal, proximal distal. When you're referring to adults and or children, everything in you is proximal, everything away from you is distal. So when someone's putting a catheter in, we often want to know what the proximal end is, that which is closest to where we put it in, and what hole is distal, which one is furthest. So if you ever take a chance to look at a catheter in an intensive care unit, there are 3 holes typically, 2 in children because they're small, but we have the end that's closest to the vessel, all right, that sits at the end, and we have one that's a little further out. We call it the distal end. A lot of people like to remember them as red and blue, but it's probably better that you understand that the proximal one is probably the one closest in to the vessel and the one further out, because you'll see the little holes on the sides. When they refer to proximal distal, it kind of goes in a lot of different kinds of directions, but we often think of it as proximal distal. We often think of things as cephalocaudal, and that's the way kids tend to grow. They grow from the inside out. So bones, which people think of, well, as somebody's getting taller, the bones are just getting longer. Well, actually, the bones grow from the outside and get longer. So if bone starts here, the outsides are growing, the inside will always stay the same. So we call that proximal distal growth, okay? And so we pay a lot of attention in orthopedics in kids when they break their wrist or something like that, because we're looking at the tip end of bones, and if that area is damaged, then we might have some problems with the way a bone heals. In other words, if the bone stops because it's been damaged at the growth plate, the tips of bones, here or maybe here, then we might see a delay or a stunting of the growth. So that's an important concept. All right. And there you go. All right, so cephalo, head, caudal, butt, proximal, inside the chest, out to the arms and legs. Okay, cephalocaudal. Okay, so obviously I've spent a little more time already talking about the factors affecting the growth and development. Obviously, these will all affect things like, we talked genetic, we talk about chromosomal kinds of things, we talk environment. I've spent a little bit of time talking about that. So there are things that we know can cause tetragenic irreversible changes in children. They've been researched through the years. Thalidomide was thought in the 1950s and 60s to suppress nausea and vomiting from the women who had hyperemesis when they were carrying the fetuses in their early points of growth. What ended up happening is that DNA or that drug metabolized and caused a irreversible tetragenic to the fetus such that children were born without arms and legs, okay? Antidepressants, anything in this list, heroin, tobacco, alcohol. You've heard many campaigns about children, premature infants who have alcohol dependence or born with drug dependent related to those dependencies will have, if they are born prematurely, they'll typically have effects to their brain. So again, we look at tetragens like those and we advise and teach against those in the pregnancies. Infectious teratogens, we think of, there's a classic acronym called TORCH. It's sort of listed here, but TORCH is an acronym for these things. Toxoplasmosis, other, which we will know, rubella, cytomegalovirus, and the herpes virus. All those infectious illnesses can cause damage to the fetus. Now, I'm sure you've heard from OB that the biggest important time is the first trimester. This is where the fetus is still developing. And this is where we counsel moms a lot not to expose themselves to people who are sick, places where there's congestion. Don't change the cat litter for toxoplasmosis because of the fumes that could get in and possibly cause fetal damage. So the TORCH is the acronym that we use to remind ourselves what infectious illnesses can cause devastating, irreversible damage to the kids. We talk about family influences. I give you a couple of examples with that. Some people focus a lot on birth order and developmental delay or stress. I don't know, it's getting a lot of play, but and family size. Obviously, there are people that have very successful big families and people that have very unsuccessful big families, and there are people that have very unsuccessful single children and people that have very successful families with single children. It really depends on every individual unique situation. But you could probably say, oh, you know, look at that kid who's from there's 20 kids in his family, or it's a blended family, or whatever, but it does influence kinds of things that occur. And then, of course, in the environment, we have to look at what kids are exposed to, particularly at an early age. What city is getting a lot of attention based on this right now? Exposed to a chemical.
Oh, Michigan?
Huh?
Oh, it's not Michigan. Is it Michigan?
Detroit, or is it Detroit?
Flint, Michigan. Flint.
Flint, Michigan, because there's a lot of what?
Is it lead?
So lead gets in the bloodstream of the young baby and basically causes irreversible brain cell damage. And so these kids end up with developmental delay. And you can't do anything once it's gotten into the brain cells and damage them. It has the ability to cause a substrate that doesn't allow for oxygen to get to those brain cells. And so the kids end up having brain damage related to the inability to oxygenate the brain tissue and allow it to grow. And as you all know, in the first year of life, if the kid has to go from horizontal to vertical, there's a lot of growth that has to happen. It's not just getting up and walking, but there's a lot of things that are going on. So in Flint, Michigan, now they're having concern that a lot of these kids will have developmental delay and brain damage. Now, when the brain gets damaged, it's not just the kid won't go to Harvard, but the kid develops seizure disorders. The kid develops inability to mobilize properly. And so those are the kinds of things that we look for in children, but we wouldn't see those until maybe the preschool ages. And just because you draw a lead level on a kid in Flint, Michigan, and the lead level is above 20, and you say, oh, but the kid's moving along and stuff, you don't know what those effects are going to be when you start looking at not just physical mobility, but developmental ability, intellectual ability. All those things are really important. So that's something that's going on right now. In third world countries, we worry a lot about pesticides and pollution because kids inhale things and it puts them at risk. And obviously being around a plant that's exuding fumes of whatever, that's also a concern. So in developing countries, a lot of this is addressed and be dealt with. In third world countries, it just kind of keeps going. All right? Okay. So what influences growth and development? Again, one could say that race and cultural race kinds of things put together will impact how a kid develops. I spent a little bit of time already talking about that. Ethnicity is something that people talk about, but if you talk about race and then you move into ethnicity, for example, in the Bronx in New York, we have a Hasidic Jew population that is very, very culturally tied together, right? So with that, what you will also see is maybe some marriages that occur and children are results or products of possibly distant cousins. Now we know in genetics that when similar genes get together multiple times, this puts the child up at risk for developing certain genetic mishaps that may occur. So in the Bronx, in the Hasidic Jew population, which they want to stay together as a culture and a religious kind of culture. We see a lot of Tay-Sachs disease, which is another neurological problem in children. And people would say that's possibly because these kids distant cousins are marrying distant cousins. We see a lot of neurological mishaps that occur when we look at race and ethnicity and the need for cultures to stay together, all right? It's not uncommon in the Middle East that a first cousin will marry a first cousin. Most of the time, it's okay, but when it isn't okay, children are born with very bad neurological issues that will plague them for either a short life or a long life, all right? And so we see abnormalities that occur within the genes. All right. Other things that influence development, obviously, any kid that's born to a blended family, a kid that's developing within a domestically challenging family, those all impact development. We have done a lot of things to address those societal issues where we feel that lower socioeconomic race, ethnicity, culture has produced challenges. We put in programs that will help maybe abate some of those things that we see. One of the more famous programs that we have in pediatrics is Head Start. Head Start was, what's the one where we get nutrition? WIC, Women, Infant, and Children, was addressing nutritional deficits in the population, whereas Head Start was addressing developmental opportunities for kids in lower socioeconomic areas. So again, these programs are based off of what we see as a lack of development in children, okay? Now, there's a couple of questions in here that I think are important, and because it brings up different kinds of things that you may see in a question and then you never see again, and I don't deal with this on a daily basis, but it does bring into play different kinds of tissue. And so this one I always like to use when you say developing from the endoderm and the embryonic period. So you have to remember that there's ectoderm, endoderm, and mesoderm. Ecto being the outside, the nerves and the skins producing your sensory kinds of development. Endoderm has to do with like your GI and your pulmonary tract, the highways of which oxygen gets to the lungs and food gets to the intestines. And then the mesoderm has to do with kind of holding it all together. So your muscles and your tendons, could be your reproductive system, but it's a term that's often used, and you might see it, so I like to kind of repeat that and sort of give it to you here in the answer. Okay, now, as far as the fetal period is concerned, there's a picture in the book, and we all know that the fetus basically starts from a very small egg and develops once fertilized into a newborn. Obviously is a fully developed body with all body parts hopefully Remember that in the first trimester, a lot of things can go wrong based on exposure that mom may have, based on a lot of genetic mishaps, based on a lot of other issues that impact that we just finished covering. And so the one thing I want you to remember, and you probably got this from OB, is that when kids are born, their heads tend to outweigh their chests, and by the time they reach a year of age, that balance has been achieved. And that allows the kid to go from horizontal to the vertical. Kids with big heads don't tend to ambulate really well. So again, there's a lot of growth, not only in the 9 months of the gestational period, but in that first year of life, as body parts tend to equal themselves out developmentally. Okay? So here's some logistics, or some numbers that may or may not help you, but again, to me, the take home of this slide is that the head tends to be pretty big when a kid is born. The legs are still underdeveloped and tend to not be able to carry the weight of a big head. Here's one that you probably learned in OB, and that is one that we look at, particularly in the pediatric period in the first 3 months, is that we are focused on the weight. We want to know what the weight is all the time. It helps us with a lot of different things. But if I see a 2-month-old and the birth weight was 3.5 kilos and the kid comes in and the kid still weighs 3.5 kilos, I got concerns. I got concerns that this kid's not gaining weight. Okay? So kids will regain their weight 10 days after. And so that sort of explains why we want to see them so often, so regularly. Because they typically get discharged at 1 or 2 days post-birth, and we have a weight. And then what tells us that this kid is getting nutrition is that they start to regain their birth weight by 10 days. So we look for a kid who's discharged at 3.5 kilos from OB to be 3.5 kilos, hopefully, when they see the pediatrician 10 days later, right? Now, some kids may lag a little behind and they'll continue to be followed. But again, if at 1 month this kid is not regained and or is still at birth weight, this kid is cause for concern with nutrition. And it's not just because we want them to have big cheeks and big thighs when they're 3 months old. We know that internally those organs need the oxygen and the nutrition. And so a kid who's not gaining weight is a kid that's not getting developmentally the kinds of things he or she needs to grow. Another thing that you want to remember is that birth weight is always tripled by their first birthday. So if your instructor's saying, well, how much does this 1-year-old weigh? You can always say, well, realistically speaking, a 1-year-old should, if a baby weighs 3 kilos when they're born, it should weigh about 9 to 10 kilos at a year of age. And so there will be emergencies where somebody will say, Dr. Mize, how much are we going to use for weight here, dry weight? And we'll say, how old's the kid? 12 months old. They go, give him 10 kilos. This is the way it works, right? Because they triple their weight by the time they're a year old. And usually you're not too far off. Now, you can tell that if there's a scrawny 1-year-old versus a robust 1-year-old, then you might, err on the side of, 9 kilos to 12 kilos. It really doesn't matter. But tripling their birth weight by the 1 year of age is something that we basically, use as a good marker of approximate weight gain. The other thing is that kids are going to be 1.5 size when they're born at 21 inches. 50% of that you can count on by the 1 year of age. So a kid's going to add 11 inches to their birth height, right? So they're going to be about 20. If they're 21, they're going to be about 32. So basically, kids at a year of age are going to be 50% taller than they were at birth. So you're going to add on, 21 inches, 10 inches. So they're going to be a little bit taller, 50% more. And then the head circumference is often equal to the chest circumference. So what is that important? Well, there's some kids who have some pretty big heads, and we want to know if those big heads are related to extra fluid in their brain, if they're not developing right, or is it they just have a big head because maybe they have a musculoskeletal issue. So we look at proportion when kids are growing. We look for a big head to sort of get absorbed into possibly the chest, sort of equalizing out. And so those are the things that we're looking for in the first year of life. You get to the point where you say, well, this kid looks like they're moving normally for their age. Some kids tend to look like they have a big head. And so abnormalities are typically things that we follow and you need to pay close attention to. So, there are all sorts of formulas that people predict. I don't tend to use them. Your book likes to use them, and it's on page, that's how much 88. So it gives you the boy and the girl equations on how to solve these things. So it's 2 times the height of a 2-year-old. So whatever the kid's height is at 2 years, 2 times that height at 2 years, or 5 times the weight at 2 years. Those are going to give you approximate weights and heights for their adult measurement. The thing is that there's a lot that goes on between 2 years and 21 years. So I don't usually use that as a guidance. Girls tends to be 2 times their height at 1.5 years and 5 times their weight at 1.5 years. Why do we have girls at 1.5 and boys at 2? Do you know why? Because boys are somewhat delayed in their growth. They will grow more later than girls. So that's why 1.5 is used for the girls and age 2 is used for the boys. That's on page 88 for you. Why do I bring this up? Because it's on your damn test. So I don't use it, but the test likes to use it. All right. Hopefully, by the time people are adults, they will grow a little bit. That's the way I should look at it. Okay. So, in the fetal growth, some of the things that people are looking for is obviously the baby's going to get bigger. The muscular activity, they talk a lot about, but one of the things we cannot tell is neurologic function per se. We don't test in fetuses for their neurological function. But we can tell by sophisticated ultrasound if a brain is at least structurally growing. So, back to Zika, these kids by ultrasound can be seen on ultrasound at the beginning of the 3rd trimester to have a small head, which is concerning, all right? And so that brings up all sorts of cultural things in terms of somebody afflicted with the Zika virus, maybe didn't know, being followed with ultrasound, ends up having a very small head at the 3rd trimester. The total impact of that, if you just take it from 1 down, let's just say all these children are born with microcephaly. Does anybody know how to take care of a kid with microcephaly? Well, in the United States of America, microcephaly is fortunate to be able to be supported with a lot of things. 1, you get a feeding tube. 2, you get a tracheostomy, because if your brain doesn't grow, you don't breathe and you don't eat well, okay? So these kids will probably be, we like to say, gastro to G-tube dependent, trach dependent, meaning they'll have an airway, artificial airway, certainly by about the time they are, well, it just depends on how massively microcephalic they are. So the brain basically is driving the train on that. And they many times will be ventilator dependent. So thinking about all of that when a child is born with a microcephalic head is something that impacts family, environment, culture, population. Now, people are talking, because you cannot detect this microcephaly until the 3rd trimester, women are desperate not to have that birth. And so people now are bringing back the idea of the 3rd trimester abortion, which is not a pleasant thing to think about. But these are people that are faced with drastic situations, that are looking for drastic solutions. And then right in the middle of all that is that if you are at risk for Zika virus, let's focus on Zika because it's big time. The president's going to address it. Certainly we have many Southern Hemisphere countries dealing with it. But if you're in the middle of that, now people are talking about any childbearing woman will not be allowed to be asked to, will be given birth control because they don't want the risk of the baby being born with microcephaly. Because it has massive impact in the society in terms of relationships, very small, to the mother having to take care of the child, the family having to take care of the child, and then the technical support for children who are microcephalic. some people can't afford it, all right? Now, if you go back and look at Zika and you say it started in Africa, why are people in Africa immune to the Zika virus now? Well, because they've been exposed to enough that the bodies have developed an immunity, meaning that anytime you get bit by a mosquito, maybe in those countries, you have antibodies that will keep the basic infection at bay, all right? So that's how immunity develops. But what about women who bore children in Africa while they were not immune, right? Because you have to develop it, right? Well, I don't know. I don't know if people have gone back and looked at it, but there probably are children that have survived with severe neurologic devastation. There are probably children that died very young, and then there are things in between, situations in between. So that's how those kinds of things occur and evolve. So again, you want to think about the trimesters, and the first trimester being very much where a lot of problems occur. Second trimester is sort of a growth of the musculoskeletal, the baby grows. And then the third trimester is a trimester where we can actually pick up issues that are going to occur once the baby's born. Okay, so now the baby is here, and so a lot of talk about how babies have gross motor movement, and we pay a lot of attention to this. I'll give you my philosophy or my idea of how babies start in a horizontal position and at 2 months increments. Do you remember this? That they gain control. So here, gross motor movement, and it's gross because it's not fine motor movement. We'll talk a little bit about fine motor movement, but the gross motor movement is basically going from controlling your head, controlling your chest, at 4 months, controlling your butt if you're sat at 6 months, rolling over or getting on your hands and knees, more hands and knees at 8 months, standing holding on at 10 months, and then taking your first steps at 12 months. That's sort of an average way of looking at things. Those are gross motor development that we look for in children, all right? Now, by now, you might have been exposed to children that may not meet that growth development, and that's an important thing to remember. Because if kids don't meet those gross motor development, that's motor development, physical development, by the age of 12 months of age, they probably will have a persistent developmental delay for the rest of their lives, okay? Now, you can say, are there kids that just have gross motor movement delays and are fine? Yeah, cerebral palsy kids, 30% of those kids do not have intellectual disability in addition to their gross motor development disabilities. They have actually normal mentation and are able to succeed. They might be wheelchair bound, but they're able to go and have a normal education, develop other ways, but have physical deficits, okay? So some things that you have to remember. Now your book has a lot of nice pictures about how kids tend to go from that horizontal to that vertical position, pages 92 through, lots of nice pictures, and then going all the way up through adolescence, but then more graphic pictures. But gross motor development basically is big chunks of the body getting developing, all right? Now, other things that we want to think about are sensory organ development. So we've got gross motor movement and we have sensory. And a lot of people don't understand that kids don't really see great at birth. A lot of devotion and attention is put to getting that beautiful mobile, but in fact, children don't really see or appreciate mobile when they're born, and they develop into it. And it has a lot to do with the brain intercepting images and processing them within the brain. Some of it is repetitive images that they see, and the brain processes that, and then they become more and more developed. Remember that not only, when you talk about senses, we're talking about an interaction with the autonomic and the sensory nervous system. That is still growing until about the age of 2. So a lot of these things are developing all along, and they need to be nurtured better. We've got the interface of spinal cord reflexes. We've got autonomic, which is parasympathetic and sympathetic reflexes. And we have cerebral, brain, and fine motor skills being all very immature at birth and growing not just as the brain grows, but as exposure and repetitive images slash experiences that the child has. We like to think of, and we call this endearingly to young newborns, and they're called stupid babies because they don't know what to do sometimes. So when a kid is breastfeeding at maybe 2 weeks of age and starts to cough and sputter, it's because things are not working 100% all the time. Remember, if the brain is growing and the nervous system is developing, kids will have snafus. It's the other thing is that remember that the brain is growing such that we have to give it room to grow, and so we have these things called anterior and posterior fontanelles. So the anterior fontanelle is the big hole that closes at 16 months. Write that down. And the posterior fontanelle is the one in the back that closes at about 2 to 6 months of age. All right. Is it bad that a fontanelle doesn't close? Well, it probably doesn't close for a lot of reasons, but you want to make sure that you understand that these fontanelles are to allow the brain to grow, and as it grows, these two holes in the cranium will seal up to protect the brain, which is kind of a nice way to look at it. And why do we have fontanelles? Because babies typically come through a birth canal, and the cranial bones need to shift to allow for that. Now, a lot of people have C-sections, but that's only because something structurally is not allowing the baby to be delivered. But these fontanelles stay open so that the brain can grow. Now, when the fontanelles close too soon, the brain is going to be kind of constrained, right? And so we call that condition craniosynostosis. And guess what we have to go do? What do we have to go do? Anybody know? What do you think? You're a plumber. What are you going to do? You want the brain to grow, you want to give it room, what do you have to do? Just comes to mind? What? You have to what? Open it back up, right? So these kids will have restructuring at a very young age to basically stretch the suture lines so that the brain can grow, right? And so they have to go to surgery. And sometimes you have to resect the frontal plate and pull it forward and open up that suture line so that the kid can grow. It's a very bloody procedure. And so when you think about it, and you have to do that kind of surgery on a kid, you say, well, you know, the brain's going to grow. But the thing is that if you don't monitor these kids very closely, they could lose a lot of their blood supply. Because if you figure they only have 90 cc's of blood in a little body that's born, maybe 120 by the time they're 2 months of age, you could easily lose a bit of blood, and the kid could become hypertensive. So again, craniosynostosis is when the fontanelles close too soon, not allowing the brain to grow. And so we go and repair it. Now, as far as eyes, I basically told you that images get repeated in the brain is growing, and the kid basically starts to see things. They could probably read a textbook by the time they're about, if they can understand the words, I'd say about 9 months of age. But they develop their sight over the next 2 years of life. So a kid really doesn't pass its Snell in 2020 until they're able, 1, to cooperate, 2, to be able to say the letters, which we can. So we have Snellen charts for kids that have boats and cats. But really, 20/20 vision is not at birth. It develops and it gets there about 2 years of life. The ears, basically, it should be intact when babies are born, and hearing is, again, a developmental thing. Constant noises that they're used to, they develop. There will be an image to the brain will then process it. Smelling improves as children become older as well. Maybe their smell is intact by the time they're a year of age, and all you have to do is put different smells in front of the 1-year-old, and if they wrinkle up their nose or if they accept the smell, you'll know that they've developed. So it's an acquired thing. Okay, so palate should be developed by the time the baby's born. We know that cleft palates, clefts can occur with children as well as lips. So cleft lip and cleft palate are newborn abnormalities that need to be addressed. Remember that just because you have a hole in your palate doesn't mean that junk goes up into your brain. Your brain is protected by dura. So even though there's a hole there, it's a cavity, and so kids can eat with the cleft palate. It's kind of hard because if you have a hole there, you basically don't have good suction, and so you can't swallow it. But all the other structures hopefully are intact. Now, I just want to say this, write this down too. 10 teeth, no teeth at birth, teeth start coming in at 4 to 6 months. By the time you're 2, you should have 10 up and 10 down. That's important. No teeth at birth, eruption between 4 and 6 months, 1 or 2, but ultimately ending in a prize of 10 up and 10 down. Remember, in the human development of things, big molars, wisdom teeth, don't typically erupt in many people, and so they need to be excised because they throw the jaw off, right? Because they tend to stay down and don't erupt through the jaws. Okay, other organ development. So there's some things I like to say about this. Skin tends to have very loose skin when kids are born, and as they develop more fat tissue that fills in. We like to call that brown fat that is underdeveloped in a newborn, and it tends to develop, and then kids are pretty cheeky by the time they're 2 months of age. So brown fat is replaced by subcutaneous fat. Remember that kids are born with fine hair, that's called menudo, that tends to reabsorb and disappear within the first 6 weeks of birth. Terms like vernix, which is that cheesy type of exudate that is from the placental fluid, covers newborns, doesn't really, once it's washed off, we don't see a lot of it. Sweat glands tend to be very immature in the newborns, and they tend to open up. And some babies will have baby acne. That doesn't mean it's a precursor of acne when they become adolescents. So cardiovascular-wise, what's important to remember is that babies are born with 2 holes because of their fetal circulation. So babies basically have a hole right here. We call that the PFO, or patent foramen ovale. And basically, this in utero allowed blood to go back and forth, and primarily forward through the left side of the heart, so it can take oxygenated blood to the body. And that's related to the umbilical vein and umbilical artery. Okay. The other one that they have is in order for the lungs to get blood. We call it the aorta here, and the pulmonary right here. What do we call it? PDA, the patent ductus arteriosus. And this allowed blood to go through the right side of the heart, through the left side of the heart, through the aorta, but also transmit oxygenated blood to the lungs. So basically, these two allow the heart to grow and to move blood from the mom through the umbilical circulation, the placental circulation, to the baby. And these are the 2 openings or connections that allow the fetus to grow with oxygenated blood. When the baby's born, the mere pressure of babies taking the breath in and the heart beating on their own basically flaps this hole shut. So the patent foramen ovale, the PFO, basically snaps shut because the pressure in the left side of the heart on birth will be higher than the right. So that just flaps shut. Right? Exposure to oxygen when the baby's born will constrict the ductus, and so typically in most cases that ductus will just basically the oxygen will constrict it down. Now you know by now that there are kids that end up having a persistent PFO or an open patent ductus arteriosus, so we'll talk about that when we get to cardiac. But for the most part, this is what happens. Okay. Now, in utero, you would be interested to know, even though the heart rate is 120 to 140, basically the cardiac output is rather low. So with these 2 things shutting, the cardiac output basically picks up. And so even though infants are born with a heart rate of 120 to 160, over the course of a year, that heart rate will typically start to drop, okay? Because blood will be more efficiently getting to the tissue, and the heart becomes more efficient. And so typically kids' vital signs, heart rates are about 120 to 160 at birth, and they come down. I'm just going to take an offshoot and talk about vital signs. When you're taking care of kids and your clinical instructor says, well, what's the normal vital signs for this age group of kids? So probably the most important set of vital signs is going to be your infant, right? Because they're just going to be a slightly different animal. So here's what I would suggest you do. Okay, what's the normal blood pressure in an adult? What is it? Right. So 120/80. So here's what I suggest you do for the infant. Okay? Take 120 as your bottom heart rate in an infant. Now we're talking infants that are 6 months and months, right? Add 40 to that, which is half your diastolic of your adult. You got 160. So here you got your range of heart rates in the infant. Okay, 120 to 160. Now by now you've had a clinical experience where you say, oh, I've seen kids who have heart rates that are 90 and 80. Well, yeah, that's pretty true, but we're trying to give you a baseline on what to go with, okay? So when we have little infants in front of us and we're giving them medicines and we're worried about their heart rate, we have to go back to a baseline. And we say, well, you know, the kid's only 2 months old, he can have a heart rate of 140. You know, and then you walk out of the room and you take care of a 4-year-old, and you have to sort of switch. Everything starts to come down. And my point is that 120 to 160 is a baseline that we go by, okay? Now, can you remember that 120/80 is a normal goal? So that's your heart rate, okay? So a lot of people like to talk about a vital sign called blood pressure. But if you take 80, bring it over, that's the systolic in an infant. So when you take a blood pressure in an infant, typically 3 months to, 9 months of age, the systolic blood pressure is somewhere starting around 80, all right? Which gives us a little leeway, because if you have a 1-month-old and you get a blood pressure, systolic blood pressure of 70, you're okay, you're within striking range, okay? But the blood pressure systolically is 80. Now you're saying I missed the diastolic. We don't typically get diastolics in infants. Why? Because they score too much, number one. Number two, it's not really, a diastolic is indicative of left-sided heart pressure. And we don't really see that. What we want to see is a blood pressure of 80. And if you ever ask me, what's the least important vital sign that I want to hear about, it's probably going to be the blood pressure. Why? Because heart rate and respiratory rate drive a kid in trouble. All right? So I look at those two things, and I look at saturation. But a blood pressure is going to be the last thing a kid loses or starts to deteriorate when they're in trouble. So that's why I really don't wait for a blood pressure. So if you came to me and said, Dr. Mize, I maybe think it's in trouble, the heart rate is 200, and then you start telling about blood pressure, I would just go like that. Because I don't really want to hear about blood pressure. We want to see a kid who's got a heart rate of 200 and see what they're doing. They're screaming and yelling and crying, and I'm going to be okay. All right, so blood pressure. But adults know blood pressure for you to focus on. The respiratory rate, right? So if you were to take 80 and divide it by 2, you'd end up with the bottom average respiratory rate. Fast. Why? Because they're moving fast. Because they don't have an efficient heart. Because they need to get the oxygen out. So 40 is an average respiratory rate. We start to worry about kids who have respiratory rates 60 to 70. And that's when you'll see what? That in order to do what? What do you think? If you're breathing 70 breaths per minute, you got to eat. What are they going to tell you to do? Make the kid what? What's that word? Those 3 letters. NPO, nothing by mouth and plastic, right? So when kids are routinely breathing about 70 breaths per minute, we're going to tell somebody to hold off feeding them until we can sort it out. So if you have a kid who comes in, he's got junk coming out of their nose, and they've got, looks like they're working hard to breathe, and the respiratory rate that you measured by counting it, not by looking at the monitor, okay, is about 75 breaths per minute. Typically, we're going to ask you not to feed that baby until we can sort that out, okay? Now, of course, if they're crying and screaming because they want to eat and they're breathing 70 breaths per minute, well, that's a different story. But if they're asleep, laying in the bed, and breathing 70 breaths per minute, and kind of looking like they're working hard, then that we call respiratory distress. And then we would hold it off. So 70 tends to be the guideline, okay? So if you're walking around at HKU or INOVA or whatever, and your kid's got a bad cold and they've been admitted, and you notice that their respiratory rate over a period of time. Remember, vital signs are not for us to look at one time. Vital signs should be a pattern of what you see with your patients, right? So just because you picked up a saturation of 82 when the kid was screaming getting a diaper change, doesn't mean you need to be concerned that this kid is hypoxic, right? But once the kid's settled down and you watch this kid continually for 15 to 20 minutes, and you say, oh my goodness, look at the saturation is 82%. That's concerning, okay? All right, so respiratory rate. What's another vital sign? about temperatures, it shouldn't change in adults or kids. Just because you're a kid doesn't mean you get a higher or lower temperature. All right? So kids who have low temperatures are more concerning to us because if they're little tiny babies who have not a lot of subcutaneous fat and they become hypothermic, then we're going to be worried. So we need help to keep the temperature up. All right? Now, there are kids, microcephalic kids, who don't have a good temperature gauge in their brains, and so their parents will tell you, well, no, they don't usually have a temperature much above 36.5. We know that because if we're taking the temperature and the temperature is 36.5 and we go, oh my God, this kid's hypothermic, well, maybe not because of their gauge. So again, unique situations call for a unique understanding. All right, so you all learned these are the vital signs, but I have one other vital sign that I love, and that's the saturation of oxygen. How do you get saturation of oxygen? What's it called? What's it called? Pulse ox. Pulse oximeter, right? And we put those on extremities, right? And when the little light picks up, and what does the light pick up? What is it? Not the hemoglobin per se, because the hemoglobin would be 12 to 36 in an adult, 10 to 30, something like that. But what it does pick up is the saturation of oxygen on the hemoglobin, all right? So, here's the thing. Normal saturations, another good thing to remember. All of us should be getting an A all the time. 95 and 100. Doesn't matter with kid, doesn't matter with adult, okay? So just because you're on HKU and your kid has a saturation of oxygen, unless they have a cyanide defect, if they don't have saturation of 95 to 100, there should be a reason you're told why, okay? But everybody should have 95 to 100, and that's how you explain it to parents. And why am I going through this? Because most of your job as a nurse, 50% of the time, you are going to be educating. You're going to be educating the patients, you're going to be educating families, okay? So you need to know this stuff and you need to know how to explain it so that someone trusts what you're saying, right? So you need to understand this. So the best way to explain it to parents is that everybody must get an A on saturation. And you explain the monitor to them and they calm down about 80%, all right? Because they want to know all about the monitor. The other thing is that, remember, vital signs is a pattern of numbers. It is not a picture once. So if you are looking at a kid once or an adult and you see vital signs and you go, oh my God, is it a pattern? Is it a pattern? We don't need to know the one time that the kid wasn't picking up on their pulse oximeter and they had sat or 72%, right? Right? So these are the vital signs that I like you to know. I know your sixth vital sign is what? What did you call it? Pain, right? And that's another category for me. These are vital signs. They're vital for you to know. When I teach, when you are there in the setting, you need to have an understanding what the general set of vital signs are with your patient, particularly if they're getting into trouble, all right? So the ones I really focus in my practice is this one, that one, and that one. The other one, questions? Vital signs. 120 over
What did
80.
she say heart rate was supposed to be? No, heart rate.
Okay, so this is infant
No,
vital
heart
signs,
rate, not
okay?
blood pressure.
Sort of based off an adult situation. All right,
Oh,
what
120
happens overall? So heart rates tend to go down as kids get older. Blood pressures tend to go up. Respiratory rates tend to go down. These stay the same. Okay? Now, depending on the situation, you're going to have an idea. So if you have a 10-year-old who's morbidly obese, above the 95th percentile for their weight, then I would focus on the blood pressure, right? Because obesity, hypertension, not good, right? But they also might have a different heart rate, might have a different blood pressure. Every kid, I can tell you, every kid has their own unique set of problems, okay? So one microcephalic kid is going to look different from the next microcephalic kid. One kid with heart defects is going to look different from the kid with the same heart defects because everybody's individual, all right? And that's another thing you should remember as nurses. Everybody's got their own unique presentation. Yes, you're going to say, it's easy to say, do you have the bronchiolytic in room 502? No, I have the asthmatic in room 513. No, you have the kid who has asthma in 513, and I have the kid who has bronchiolitis in room 502, right? So it's easy to get into those I deferred, right? Respiratory rate, or respiratory system. Okay, so here's something to remember about respiratory. How many of you ever had sinus infection? Nobody? Okay, they're not fun. Headache, sinuses, right? Kids don't have sinuses until they're about 6 months of age. You just kind of look at them and haven't been developed yet. So kids under the age of 6 months do not get sinus infections. Sinuses develop, they're fully developed at 6 months, and potential for sinus infections. The respiratory system is responsible for inhaling oxygen, getting it to the tissue, and getting rid of CO2. This is a big deal for kids under the age of 4 years of life. Because anytime the lungs get inflamed with an inflammatory virus, these kids get into trouble, and they get into trouble quick. And you cannot breathe at 70 breaths per minute for very long without a little bit of help. So we do a lot of things for kids who have respiratory problems. So the lungs are immature until they're about 2 to 4 years of life, and so they take a hit. And so the hit they take is that they're exposed to a lot of different germs and viruses and infections, and so they work a little bit harder. So the respiratory system is broken. Okay, so GI. So how much does the stomach hold when a kid's 1 month old versus how much does an adult stomach hold? How much does your stomach hold? And you should know that because you do bolus feeds right now, right? Anyone done bolus feed in an adult? Anybody got a bolus feed? NG2. Look it up to, what's an adult formula? What do you guys do? What's the boost, right? Boost is something.
Oh, like that.
Adult, like we use Pediasure, we use Nutrin, we use,
Oh,
what's an adult?
they have Ensure.
Ensure, there you go. So how much is an Ensure bolus feed? Done that yet? What's a bolus feed? Anybody know what a bolus feed is? Anybody? So you stick an NG tube down somebody who can't eat, right? Or you have G tube, right? So you gotta give them calories, right? So you calculate that. So typically the stomach on an adult, I think, would probably hold what? 300 cc's? Yeah, something like that. Actually, an infant, 1 month old, can hold about 10 to 20 cc's. So newborns eat a lot frequently because they can only hold so much. And it stretches really fast, such that by the time the kid moves to a year of age, they probably could hold 100 to 200 cc's, such that when you become an adult, you can hold 360 cc's. And you can figure that out, right? Because some of you have your water bottles here. So what is that hold? 500 cc's, right? Something like that, right?
Yeah.
I mean, it holds. So if you figure, let's just do it this way. So most of them are not measured, but a water bottle holds 16 ounces, right? How many cc's is that?
About 500.
You know how to do that? How much is it? On small water. How much? 33 ounces. Okay, so double this. So 760 cc's. Can you drink that over the course of the day? So 16 ounces, 2 cups of water is 380 cc's, okay? You're gonna know some of that kind of stuff, okay? So when you drink a glass of water, a 16-ounce glass of water, or a 16-ounce glass of beer, basically it's 380 cc's. Do you feel a little full? Yes, that's how much your stomach holds, okay? So think about a little tiny baby can hold 10 to 20 cc's. By the time they're a month old, they can hold about 100 cc's. And why is that important for you to know? I don't know, because you sort of should know stuff like that, right? So that when somebody says bolus this baby, or continuous feeds, or something like that, you should have an idea of what you're doing. Don't ever practice and not know, sort of have an idea of what you're doing. Now there will be plenty of things that you won't know what you're doing, so just go home and make sure you teach yourself what it is you didn't know for 12 hours while you were doing it, right? That's important. But rule of thumb, don't ever give medications you don't have any idea what they are. That doesn't mean you should not know, you should know every single side effect and all, but if you go and give gabapentin for 12 hours and you don't know what gabapentin is, is irresponsible, all right? Go find out what it is. Take the phone out, Google it, find out what it is. Yeah, sure, you probably wouldn't know some of the adverse effects, but that's okay. You're giving something to somebody that could cause some damage, so you should really know what you're doing. So some of these things become important, particularly in kids. All right, so then what about the GU system? Wait, can I go back to respiratory? I just want to mention one other thing. So I didn't mention something called surfactant. Surfactant is basically available to fetuses at 32 weeks of fetal life. And so that is why people try really hard to keep fetuses inside their bellies until they're 32 weeks. Because if you don't have surfactant, that means you have no glide with your lungs. So every time your lung inflates, it has to rasp against some dryness. So at 32 weeks, surfactant becomes available. And so babies can be born after 32 weeks and suffer relatively small problems. So when parents say to me, oh yeah, my baby was premature at 37 weeks, I really don't worry about that. But if you tell me that your kid was born at 28 weeks, I'm going to worry about their lungs because their lungs took a little bit of a hit, all right? So surfactant at 32 weeks gestation, all right? The other thing I want you to remember about kids and respiratory is that before the age of 1, because they're stupid babies, babies are obligate nose breathers. That means they're obligated to breathe through their nose because they're obligated to eat through their mouth. So let's think about that for a minute. Obligate nose breathers, obligate mouth eaters, right? So what does that mean? That means that when a kid gets a bad cold and has snot up their nose, are they going to breathe really well? No. Are they going to eat really well? No. Because you have to breathe while you eat. So if you have a nose full of snot, you're not going to eat really well. So that produces two problems. One is respiratory distress, because they can't breathe through their nose, but potential for dehydration, because all you're counting on is mom's breast milk before the age of 6 months, and you get a bunch of snot in your nose, you are going to become dehydrated if you aren't able to eat, right? So babies with noses full of snot are at risk for two things. They're at risk for respiratory problems and dehydration, because their sole source of food is milk, right? Breast milk or bottled milk. So one of the things you learn as a pediatric nurse and you teach parents to do, which is it's not a well-respected trick of the trade, and that is how to use a bulb syringe to show parents how to pull the snot out of their kid's nose. Because they're obligate nose breathers and they're obligate mouth breathers, okay? And that then sort of changes between 9 months and 12 months. They get it. They say, I can maybe breathe through my mouth a little bit, but not really. I mean, you know when you have a bad cold, do you like to breathe through your mouth? No, but you can do it, right? Because your brain will tell you, get the air in. Babies are stupid. They don't remember that kind of stuff. But maybe by the time they're 1 year of age. So an asthmatic who's 3 years old, who's got a bad cold, comes in mouth breathing, that's a problem, right? So you got to think about little things like that. That's how our kids get in trouble. Okay, let's talk about GU. The renal system is fully mature at about 2 years of age. And how do you know that happens? Do you know that because of renal ultrasound? No, you know it for one really important reason. What is the most important accomplishment a toddler can have? Gets them into daycare. This is one box you gotta check. What? Body training. You know the kidneys are fully mature, right? That means that mature meaning that bladder fullness is sensed by the brain, and the kid can hold on to it and maybe pee into a toilet, right? It's also processing electrolytes and everything through tubules. It's just doing a better job. Okay? So how much do you think a bladder can hold as a newborn? Now I give you the answer. 30 cc's. So little guys can only hold about 30 cc's. So when it tells you to cath in and out cath as 2-week-old, don't be looking for 300 cc's, which is what a typical void is in an adult every 4 hours. So they can hold 150 cc's when they're 3 years of age. And I don't know that because of the bladder scanner. I just had to look it up, all right? So newborns 10 to 30 cc's, 1-year-olds or 3-year-olds 150 cc's, and adults 300 to 400 cc's in their bladder at one time. That's good to know. Endocrine system, again, is fully maturing as we go. Remember, endocrine is the chemical system that keeps things in check. Thyroid, pituitary, all those kinds of things, okay? All right, let's take a break. What time do I have you to?
9:30.
10:25, something like that? Is that right? Okay.
Is Christina okay? Hmm?
I was training. How can they make you train if you're pregnant?
They don't care. I mean, I don't do any heavy lifting, so.
Did you run and stuff?
No. Hell no. Walking up this flight of stairs is like painful.
I'm tired.
Why are you tired?
I don't know. I just haven't woken up yet. Oh yeah.
Super Bowl commercial sucks.
Okay.
Did you watch the Super Bowl?
No. I just didn't.
And
Didn't
The
care.
halftime show was awesome, though.
Is it
I
good?
love Coldplay and Beyonce.
Like Beyonce.
Bruno was cool.
Like it, like
Huh?
Coldplay was like,
Coldplay was like,
I was like,
Coldplay was what?
he was so whatever. But
No, I like
Beyonce and
Coldplay.
Bruno.
I want them to get back together, but
I don't know my stuff is here.
I can totally see your nipples.
Oh God.
What happened?
We're all girls here. She's like, you can see her nipples. My
Jane likes it when
no, I
people
don't. Just when I get
know.
dressed in the morning, I'm like, what can I put on where I don't have to wear a
Is
bra?
Marshall there? Oh, he's there all the time, isn't he? How is he?
He hurt his leg, and I just can't have him around the house anymore. I just want to kill him. I don't know.
He didn't watch the Super Bowl either? He's not a sports guy?
He went to his mom's house and watched it, and I was like, oh, I can't. I have so much work.
And you just slept.
Yeah, well, I've never seen Breaking Bad, and I was watching that.
You started it?
I saw the first 2 seasons like when it first came out years ago,
Okay, I think
and then
need
I
to start
hadn't
that.
seen it.
I mean, not anytime soon, because I need to study, but...
And I was watching it. I don't know what all the hype is about. I mean, I know it's really, really good, but when it was on and it was like the end, everyone was like, "This show is amazing." My brother said it was better than The Sopranos, which is like, it's not. Anyway, I was doing that, and when he came out,
Sopranos?
it was a reach.
I like...
Driven, and the driven need of the human is to resolve conflicts. And so this table up here, in terms of his stages of psychological development, is surrounded about sexualities and sexual cases. So you intermingle this with kids, and one of the more common phrases somebody said, "Oh, that's a Freudian slip." And what Freud was basically saying is that the child develops to control their id, their uncontrollable. So Freud used to look at kids from a developmental stage and say if they didn't have, if this was defective one stage, again, it's a kind of building on top of another. So we really, when we talk about Freud, we talk about things like oral focus, and so you see that the infant tries to put everything in their mouth because they get their stimulus and satisfaction under control by getting something orally. So a lot of attention is paid to putting pacifiers in mouths, letting kids suck on their hands and feet, those kinds of things. The second stage is the anal stage, which is probably toddlerhood, where a lot of focus is on potty training and controlling their bodily functions, their bladder control, their bowel control. And so Freud would say getting that id under control. The next one is the phallic, 3 to 6, we call that preschool age, but this is where we hear a lot of concerns from parents about children masturbating. And this is trying to get that under control, and that is sort of driven by the cultural norms of what's acceptable and not acceptable. And so Freud would talk about masturbating as being something to release the hidden frustrations that someone is having. Latency and genital basically move further into controlling the overall sexual urges that people have. And And so we sort of mingle that into kids in terms of how parents rear their children to control the id in them based on the Freudian stages of development, and understanding that masturbation between 3 and 6 years of age is something that may or may not happen, and it may happen at an inopportune moment, but it is part of something that a child works through their rearing and ability to control their urges. So probably the one that has more sticking power with me is Erickson's. I don't spend any time on intimacy versus isolation and up and above, but I do spend a lot of time on the other stages. And Erickson is put out for you. If you're not going to pay attention to me, I don't think it's a book, but I think I mentioned it in there. Let me see. Yes, page 107, sorry. So Erickson basically talks about each one of these stages being needed to be mastered in terms of development psychosocially, and if you are weak on that first stage, you cannot really go to the second stage without showing some deficiencies. So when we're talking about psychosocial idea, we're talking about the maturation of a child moving into adulthood. We're talking about being able to deal with crises and to be able to be strong in how they feel at one psychosocial aspect, so as to not fall into the negative aspect. And so Erickson talked about first year of life in terms of their life being surrounded with trust and developing trust in their environment psychosocially. And so you could pretty much see an infant totally dependent upon the caregiver slash the mother who's breastfeeding slash the one who gives them things that will keep them warm, dry, and fed, right? So that sort of ability of an infant to be able to know that those needs, those basic needs will be met is what Erickson's talking about as a basic groundwork for psychosocial development. If that isn't met, the child has been hospitalized and gravely ill and doesn't know about those things, or they're unexpected, or they're irregular, then the child will possibly develop a mistrust in their psychosocial kind of habitus. And so I talk about the hospitalized child because that's what I'm used to dealing with, but let's talk about a Syrian refugee infant who may or may not have a parent taken away from them, or they don't know where their next meal will come from, or the child in Africa whose mother's been affected with HIV/AIDS and cannot breastfeed the baby, and that's their sole way of getting nutrition. Or simply there are no diapers to change the child, or they live in very poverty-stricken situations. This impacts the trust of a child psychosocially, because if they cannot trust on basic principles to be met, then they're going to become distrustful and mistrust their situation and be what I like to say is skittish. And so even the child who is in a developing country has massive surgery in their first year of life, or their first year of life is spent on death's door, they will have to master that trust before they can move on to the next psychosocial challenge. So those are some examples that I think about when I think about trust versus mistrust. If we move on into autonomy versus shame, this is the toddler of things. Autonomy is basically knowing you can do certain things on your own and feeling good about them, versus being doubtful that you can take that first step. So the child who's been bedridden in their first year of life is going to be behind and might have some doubt or shame related to the fact that they can't move on to doing the walking and the running and the skipping that a toddler will quickly go through. So autonomy is mastering skills like potty training. Also autonomy, standing there and saying those famous words that toddler can say, which is, what's a toddler say? Because he's already told us. One word, 2 letters. No. You always tell a toddler no because you want to keep them safe. You don't tell a toddler no because you don't want to get into something. You because basically it's working off of mistrust, will be a very shamed child who will stand off in a corner, who might be neglected as an infant, who didn't get that nurturing trust relationship. And so they then develop into a difficult to attain autonomous kind of stage, and they will also feel shame and guilt. Obviously, we know that there's a lot of non-accidental trauma out there, and these toddlers tend to be the defiant ones who get beat, and they will definitely exhibit some shame and doubt about maybe they did something wrong, because they can't process what it is that they did wrong enough to be able to understand it. So autonomy versus shame and doubt is Erickson's second psychosocial level of development. The third level is industry versus inferiority. And this is basically, initiative versus guilt, I'm sorry. So initiative basically means now a toddler has mastered skills, physical skills, vocabulary skills, other kinds of skills, and now moves on to initiative, meaning starting something on their own. Building a tower of blocks might be a simple example of initiative. Versus the child who's been maybe abused will not be able to get out of the shame and doubt enough to feel like they always feel it's their fault, or they process it as, I better not do that or I will get blamed.
So is it better to start disciplining them at the age of 3, or if they're not?
Discipline is an offshoot of keeping the child safe. In other words, teaching them things that will keep them safe and not get hurt. So discipline could be as much as getting your child to sleep 3 hours through the night, or something like that. So you can look at discipline in a very different way. So I like to think of keeping kids safe and teaching them how to move on. But yeah, discipline, a lot of people will think that a child who should be potty trained at the age of 1 and will do whatever it takes, and so they don't understand that the child needs to make some mistakes in order to gain that trust from them, and then to gain that autonomy that they can hold their bladder or their bowel to get to the bathroom. And so initiation is seen in the preschooler, where they get ideas and they start to act on those ideas. So I'm going to build the best tower ever, because they've been told that, right? Or I'm going to go to preschool and I'm going to play with my friends. Or I'm going to eat this loaf of bread. Or I am going to, a lot of it is associated with confidence and success in play, because play for children is work until they get to school, and then they start doing an advanced work, play kind of thing. So initiative versus guilt is that preschooler area. Then we move on to industry versus inferiority. This is the school age psychosocial development. Industry is about doing the work of play and doing the work of school and learning. And so school age kids are very industrious in how they set about doing things. So one example that comes to mind is that they have their own hobby. They start to do group sports, and they are all about the accomplishments in a very small way, but moving on to more important things. So industry for the school age psychosocially is doing things that are presented to them with the skills they already have and accomplishing them. It doesn't mean that they have to get every goal on the soccer team. It just means that they get in a group and they're able to work with to produce a product, okay? Versus inferiority, and this is where the big concept of bullying comes in, and someone who makes them feel like what they're doing is not accomplishing the goal, but in fact they're inferior. And so we focus a lot of psychosocial attention these days on bullying, not just cyberbullying, but bullying on the playground, bullying in the classroom, bullying wherever, bullying from parents. In other words, the psychosocial development that must be avoided is this idea of inferiority. Now, some easy or sort of soft inferiority things is how to deal with a child who has been pretty much up until school age able to go to parents or their caregivers and say, it's okay, isn't it? And most of the time caregivers will say, yes, it is. Now, when you get a B in school or you're starting to get grades, now you're being judged by a different level of rules. And so inferiority psychosocially might be that you're not always number one in the line. You're not always getting the goals. You're not always possibly excelling. And so that is where kids struggle with a little bit of inferiority. And this can become psychologically very devastating to those kids. You could well imagine that a child who's been hospitalized might feel a sense of inferiority because they're not able to do any industry. So the child who has a simple appendicitis is in the hospital for a week or 2 days or whatever, and isn't able to play the soccer, or isn't able to play the game, or isn't able to do something, might feel a temporary stage of inferiority, all right? So the drastic ends of this is where we have bullying, or we have the child being told that they're not good enough because they're not achieving things, versus small stages of I didn't get the goal, or I have to stay away from my friends for I'm sick, or something like that. So Erickson talks about, going back and forth in those stages. One of the things that we see as parents as we see kids in industry versus inferiority is when they want to change the rules so that their kids always feel success. And we see a lot of that in the United States culture, where parents will do everything to make sure that their kid is number one on top. And I can think of one person right now who sort of exhibits that kind of missing the inferiority, who is a political candidate right now. But if I hear that they get up and they say things like, I am the best, there's no one else who's going to do this better, I know this for a fact, this somewhat is, we see this parents encourage that kind of behavior because they don't want them to get anything but the A. They do want them to get into the best schools. And it's something that where parents mean well for their child ends up kind of causing some problems later on. The same could be said for physical kinds of things, psychosocially. I never had a cupcake every day growing up, so if you're going to have 3 cupcakes a day growing up, and so we end up with an inferiority because we have an obese child. So I'm saying it works its way in many different ways. You just have to step back and look at it. But for me, the hospitalized child is always going to be at any one of those stages something that I have to think about. And the last one I think is identity versus role confusion, and probably one of my most favorite stages of psychosocial development. This is the adolescent. And Erickson, who talks about the adolescent, is having 4 main stages. The first of those 4 stages is it's about me. It's all about me. And nothing else. And it's got to be me, my hair perfect, me, my clothes perfect, me. I'm using the United States kid as an example. And then it's me and my friends. I don't talk to anyone. I gain my energy through me and my friends, so my people, right? So it's me and my friends can do wrong. And you can see where this can go wrong in that if kids are doing the wrong thing and you feel you have to be with your friends because you're psychosocially developing, you could end up having making some choices that will render some bad decisions, right? So it's me and my friends. Then it's me and the world. Who's paying attention to me and the world, all right? So I like to think of it as me in the world. And there's confusion that goes along with that all along, all right? And then the ultimate 4th stage in Erickson's developmental part of this identity versus role confusion is, and what am I to the world? So it's me, my friends, me and the world, and then what am I to the world? And adolescents go through that as they get, develop, and they have bouts of role confusion. Now, things can go very askew if they develop a health habit like an addiction. It could be as mild as some defeats. They don't get into the college they want, but they're not able to achieve this, that, or the other. But I'm just saying that Erickson talks about these as crucial steps in role development in terms of psychosocial stages. So those are some examples of Erickson. So if you go back and you look at the hospitalized child, I was mentioning that the child who needs to be hospitalized as a premature infant is never going to be able routinely for a while to count on all those needs being met exactly when they need them. And actually mothering, breastfeeding, changing the diaper, keeping a child clean, that's really what it's all about for the first 3 to 6 months. These needs are being met constantly and pretty much on time. Whereas if you're a preemie and you've got a bad, let's say you have an intestinal obstruction, you have to have surgery, everything gets kind of out of order there, right? So you're a little behind on that trust versus mistrust. If you're a ventilated child and an infant, you're dependent on the nursing care and the physicians to keep that trust level going. So the trust is not the classic one that Erickson talks about, and in fact it's a little delayed, and in fact there's a little bit of mistrust engaged in that, okay? autonomy versus shame and doubt, again, I look at the hospitalized child. I look at a toddler really needing to be the ritualistic toddler who needs to control their environment, and they're not able to do it in a hospitalized situation, depending on how old they are. The point is that autonomy then becomes a challenge for the toddler to achieve. And so this shame and the shame and doubt kind of thing comes into play, and the child regresses into the trust mistrust until you see a fitful, crying, chronic, colicky child. Okay, so then you go further up to the hospitalized child and you think about initiative versus guilt. Here, the child is unable to start projects on their own, maybe because they're severely hampered by a neurologic deficit or whatever, and so they often will feel guilty that they're not being able to do what they should be doing, and so this tends to have a very vicious cycle. That then rolls into industry versus inferiority, where you should be starting to be with your friends and feeling comfortable about that. And you can't do it because you have some medical condition that doesn't allow you to do that, whether it be temporary or permanent or somewhere in between. And then it just sort of falls into identity versus role confusion. So you see the adolescent who's wheelchair bound reach adolescence, and you wonder through the psychosocial development where this child is at. It's kind of a different picture than, let's say, those of us who are up walking, going to school, or doing whatever. So it's a very different thing in terms of psychosocial development. And remember that Erickson talked about this, it's an exchange and interaction amongst a environment that the child is in. So if you're stuck in a hospital bed for a significant period of one of those stages, there's some catching up to do, or maybe they never do catch up, I don't know. The point is that I have to think about that. So when we go back and think about nursing care and we think about Erickson, trust versus mistrust. Now remember that when you're doing peds, you're doing a family, right? So trust versus mistrust might be as simple as saying to the parent, you can't hold your child right now, but as soon as they're stable, you can, all right? So you have to think about that. Let's say the mother has twin triplets at home and one triplet gets sick and she's got to get home to the other two. You then sort of have to understand that the trust and mistrust of the child needs to be dealt with. In other words, you need to put time in your nursing care to hold that child, right? You don't give a bottle to a child on the bed. You have to take time to feed the child, right? So trust versus mistrust has its way of getting into nursing. When we talk about autonomy versus shame, when we talk about a toddler being restricted to a bed, whether they're pharmaceutically paralyzed or sedated, or they have a fracture or whatever, we have to understand that this child is meant to be on the go, gaining their own confidence, right? So when we don't do that, we have to create environments where they can do things. Obviously interactive toys, but not putting them in front of a video player or an iPad to say that that's going to give them the autonomy they need. It might be a temporary thing, but it's not the end all, right? And then when we talk about initiative versus guilt, we have to look at preschoolers as those who need to have projects or need to, if they can, have things that they can feel some success from. Otherwise, they're going to feel this inferiority, this guilt kind of thing come over them. So as simple as if there's an asthmatic or a bronchiolitic that needs to open up their lungs, give them charge of blowing bubbles, kind of thing. Little small things that enter into how you practice at the bedside. Now, I haven't even mentioned parents along with this, but you have to understand that parents have a big part of the psychosocial development. So if you can't provide it for the child, you got to think of examples where you can provide an environment for a parent to allow the child to somehow see some parts of the psychosocial development. Okay, so that's Erickson. I highly recommend that you look at this. It will not come to you as a specific, what is autonomy versus shame? It will come to you as a synthesis question and how you would answer that question based on the Erickson level of development that we're talking about, okay? If the presumption is on most of your Hesse and NCLEX questions is that every child is going to go to those stages at the right age. In other words, not going to be extenuating circumstances. You have to remember when looking at the question, look at the age they're talking about. Remember what autonomy is an example of. Remember what a shame example is. That's the only way you're going to be able to answer a question intelligently, all right? So they don't come to you as Remember that psychosocial development is not just the child, but it's the child and their environment, which includes their parents and their family, right? Okay, so that's important to know. Right, now, when we talk about Piaget, page 110, talks about cognitive development. Cognitive development, of course, is so Piaget talks about cognitive as a idea of building off how to put this, how they perceive then process an event or a thought, and then using the information that was pre-existent and what they're gaining from a situation. This is your cognitive development. Of course, we want to see our children grow in this kind of thing. And so the guy that basically developed the print on this and has been coming to question recently is Piaget, and he talks about accommodating a growing process of how to gain cognitive development. And so Piaget is more on, as a kid gains more information, how do they put that in order and use it to process the information in front of them. And I don't want to get deep into the woods on this, but he does have some stages that he was developing and explaining. So the birth to 2 years of age is more of an exploratory sensory motor. In other words, the senses are developing and they then push the motor. And so, we're talking about moving from gross to fine motor movement to repeated behaviors that are successful for the child. So, holding the rattle, they drop it initially, but when they hold it and shake it, they get a little more positive feedback from that, so they implement hold the rattle. And they acquire that, and then they get more sophisticated in doing that. At about 6 months of age, becoming, because their senses are more developed, more aware of their surroundings, and knowing that, for example, my grandson was over last night, and I gave him a cup of water, and I emptied the water and gave him a cup. But I gave him a cup with some water initially. So he drank the water, then I emptied it because I didn't want to spill it. So he grabbed the cup and put it in his mouth to drink it, and there was no water in it, and he handed it back to me. Why? Because what did he expect? Water in the cup. So you can see how that happens, right? And this is what Piaget was saying. Using things sensory-wise and building on those as a process. That's one of the best examples I can give you right off the press there. One thing that infants don't understand is that something that happened before might impact on what's going to happen next. No process whatsoever. It's just trial and error kind of thing. So that cup is a good example of that. One of the things that we do with older infants, 8 years, and you've done this in a restaurant or something, the infant will look at you and they'll smile, and then you'll do that, and you're trying to do a sort of far away peek-boo, and they'll keep looking for you. And Piaget talks about that as object permanence. In other words, they're at the point where maybe at 3 to 6 months, they didn't know what to make of the fact that if you put your hand up and put it down, the face is still the same. At 8 months, they're starting to say, well, take your hand away, the face will be there. Object permanence. So we start to see that in our infants, at older infants of age. And then, obviously, the biggest thing is at 12 months where we put the object over here and the child goes to look for it. So object permanence now is built onto going and looking for it. Okay? See how I developed that? Okay. Pre-operational stage, 2 to 7, so now we take toddlers through to school age. We start to see kids using a process to develop their own thought. And so there's a sort of sensitivity about, it's all about me as a toddler, meaning I'm hungry and I want something to eat right now. And so it's egocentric, right? And so what they do to work through that process is, what are infants most notably known for in terms of their behavior? what do? They start to scream and yell, and it can develop into a temper tantrum, right? That's an egocentric thing that Piaget says, is that they don't get what they want, so they start to develop a defiant attitude. And this is where, Marie, sometimes discipline can take different avenues. The child either gets indulged or not indulged, or somewhere in the middle, Piaget say, they learn to process and build on that. Obviously, in my family, if you screamed and yelled as a toddler, that wasn't going to get you anywhere. So the toddler learns that, let me try another thought process, but they're learning off of an experience, okay? It's called that peri-operation. So then maybe 4 to 7 years down the line, if not indulged, the child will then say, I'm hungry, let me consider asking for something to eat. And at 7, they might be told, no, you cannot have another cupcake. Have one, that's enough. But you can see where parents can definitely influence peri-operational stage where they say, my child will never eat anything other than vegan food, and never touch a soda, a piece of candy, ice cream, or anything in their life. But what conflicts that is that they see other kids getting ice cream or cupcakes or whatever, and so they have to process that based on what they're being told and what they see. So Piaget calls that peri-operational. And so then by the time they reach 7, they're starting to reason things. So maybe the 7-year-old who's been taught you're not going to get any ice cream, soda, or candy can say to their colleague, we don't eat that in the house. So Piaget likes to think of that as concrete operations. So they're able to reason based on their experiences and be able to get into a social situation and exhibit that. One of the more famous Piaget exercises that people talk about, and it's kind of interesting to use this reasoning in 2 to 7 years of age, is that they bring kids in and they give them a round container and a square container. And the square container might be a little bit taller, but they both held the same amount of fluid. And so the examiner would take a cup of water, pour it into the round container, pour it back into the cup so that the 2 to 7-year-old could see that it was the same amount of fluid, then pour it into the tall container, and then pour it back into the cup, and ask the toddler, preschool age kid, which one holds more? So the younger one would obviously say what? The taller one, right? But then as they move through this test, different age kids, because of course you don't do the same test on the same kids, this 5-year-old would say, I don't know. They would want to commit. The 7-year-old would say, it's the same amount. So that is one of the biggest things that Piaget would do. So you can Google Piaget and a lot of this. But so Piaget is another one where kids are using their logic and building on it cognitively to understand and to get themselves through different situations. Now, where is that coming to? Pediatric nursing, you would walk out of the room and say, I don't know what that toddler's thinking. I don't know what that adolescent is thinking. Because you're trying to figure out how they're processing things. So that's an important thing that we have to use when we're thinking about things like hurtful procedures. A 2-year-old is not going to understand it as well as a 7-year-old. So you're going to talk to a 2-year-old different than you're going to talk to a 7-year-old. You're going to not tell a 2-year-old hours ahead of time, but you might tell a 10-year-old a couple hours ahead of time, we're going to have to do this procedure. One of the more classic things that we say in nursing is that it's not going to hurt. Well, I don't know that. So I prefer to use my Piaget on the same level with an infant and an adolescent. And I will tell an infant, it's going to hurt, cry. Tell an adolescent, it's going to hurt, you can cry, okay? The point I'm trying to make is that we don't know how many kids will process things. But if you understand Piaget, he's going to say it's a little confused until they get to about 5 years of age, and they start to put some reasoning in, and then about 7, they're able to understand to a certain extent. But for me, Piaget is kind of out there. All right, so those are 3 different theorists. I think you'll see that. I would highly suggest for the exams that you look at those tables of Freud, Erikson, and Piaget, and then write down an example of what you think they're trying to say, all right? That's the best way of learning it. Now, your book gets into, well, so in summer, let me just look at certain age groups and hospitalizations, because I just want to leave it here. A 1-year-old won't appreciate hospitalization as much as a 3-year-old, based on Erickson, Piaget in particular, will see it as a punishment. Punishment for maybe something they did wrong a week ago, they just get it all confused. So hospitalization for a 3-year-old is going to be punishment. Other things that we do for pediatrics to minimize the amount of psychosocial negativity is we do things like, what do we do in hospitals to help with the trust and mistrust in terms of families and stuff? What do you see in a room? What do we do? Remember, peds is not just kids, it's families, right? So how do we help with trust? The basic principles are eating, drinking, and changing the diaper. Rooming in is addressing that developmental thing, right? So in most pediatric rooms, what do you see? You see a bed for a parent. You see those in adult rooms? No. And actually, it's starting to catch on now. You know that people want their significant people with them when they're very ill. You know, obviously. The other thing is that when you put Erickson together, and we talk about trust and mistrust, when we talk about autonomy versus shame and guilt, talk about these stages. When they are under stress, kids will regress. So the toddler may regress to a trust mistrust stage. But the thing about toddlers is that they can cry louder and longer than infants, and so they will regress. They will also regress in other kinds of accomplishments, like they may start to wet the bed. Preschooler might start to wet the bed. This is both autonomy, this is guilt and shame almost into one. And it's not just the kid, it's the parent. They get very apologetic and they'll say, he never wets the bed at home. Well, you know, it's a little stressful here. Let's just take it, you know. The other thing that nurses do that doesn't help very much is that when kids are in the hospital, what do we end up doing? We end up feeling that we have to do everything. So all of a sudden, parents who've been changing a toddler's diapers or a 1-year-old's diapers for ages get relegated to sitting in a chair as opposed to change the diaper. Although there are situations where maybe it's unsafe for the parent to change the diaper. But getting them involved to a certain amount is very, very helpful because talk about role confusion. The parent who's used to running the show, taking care of this child, is now in role confusion, right? So those are the kinds of things that come into this developmental thing. Other things that we think about with psychosocial and these stages of development are procedures that we do for kids, to kids, send them to, can bring in psychosocial kinds of negativity. So a lot of preschoolers and toddlers are going to see any kind of procedure as a punishment. And they won't like it, and they will protest, and they will try and run away. So those are the kinds of things that you need to think about and how this gets into stuff. Now, I didn't want to let this go, but temperament is another something that is important in terms of how kids handle situations and how they respond. And so the book spends the table 3-5 talking about different components of temperament, and they define temperament as 3 different categories. They talk about the easy child with the temperament. Obviously, this is the child that's adaptable to the situation, can handle all sorts of pain, and typically has a pretty positive mood about things. But kids under stress become definitely will stress their positiveness. The difficult child is the one who's most easily remembered as the colicky child, who basically takes a negative approach to new things, new stimuli, and will protest quite a bit. And they will also be typically slow to adapt to a new situation. And then the slow to warm up child, the temperament there is basically a hesitant child who will go off and see in preschool, off in the corner, taking it all in, needs to be drawn out a little bit, and so you need a kind of a calmer way to enter in. It's sort of the kid who puts their toe in the water and doesn't decide to get in right away. So again, we got the easy child, the difficult child, and the slow to warm up child. And difficult children tend to be labeled in preschool by their preschool teachers. probably don't have a lot of developmental expertise, but they'll say, it's a difficult child. Oh, it's an easy little child. It's sort of a warm-up child, you know, and maybe they know a little bit more than the rest of us. But I would focus that temperament thing is starting to get a lot of attention. Then your book talks about not gender development as much as, well, I will tell you about gender development is mostly focused on adolescence. And we think about Tanner staging, and those are more puberty staging kinds of things, and they're more physical. And so when we talk about physical development, we talk a little bit about breast budding, breast development, pubic hair, underarm hair, scrotal, penile, testicular growth. We call those Tanner stages. So Tanner stage 1 would be anybody who's not in puberty. Then as you see the beginnings of breast budding and stuff, and that's outlined for you. This goes up to 5, and then at 4 and 5 you're in adult. Page 104, again, it's just the growth of secondary physical changes related to puberty, right? Colbert has some moral reasoning stages, basically starting at about school age. Colbert talks about reasoning that the child develops related to punishment and obedience. By now they've been punished and been given the rules enough that they understand that. They talk about this stage 2 in the pre-conventional morality is 7 to 10 or school age, where they're trying to understand orientation to, if I do this, it's wrong, if I do this, it's right. And then the early adolescence, 10 to 12, a good kid always gets rewarded, a bad kid doesn't, that kind of thing. So I would just know that peripherally. By the time they reach adolescence, they know they have to go by a set of rules or there will be legality involved. So if I run a red light or something like that, if I drink underage, so that's where that 12 to 25 then moving on, I don't really get into that stage 5 and 6. Okay, now we developmentally screen our children casually in the pediatrician's office with a form. We ask parents to say, has your child done this, this, and this? And then we measure it up and we say they're on track. And then there's a lot of developmental things, psycho, cognitive, and physical that go into this. Or we ask parents, like, can the child build a 4-block tower and a block tower? And then the developmental screening tests that are more official are often used in premature clinics, preemie clinics, where we ask the parents questions, a barrage of questions, and then we watch the child and see if they match up to the answers the parents have been giving us. And so those are things that are very helpful in terms of knowing if a premature infant is at risk. And it's often done in a very quiet environment, not done in the home where the child can be distracted. And that's this thing there. I would also just there's a lot of good tables in this chapter. Page 116 talks about language development. I can just give you some of it. For language, we have kids will do 5 words by about the age of 1, then rapidly in toddlerhood up to 900. By preschool, they'll develop another few thousand words, so that they have a decent vocabulary by the time they reach school age. So again, first few words at a year of age, then rapidly moving to about 900 words by the time they end up with toddlerhood. And remember that short sentences, 2 words developing into longer sentences. And then I would say that preschool is the one where they really develop the ability to speak quite fluently. And so I would just look at that. All right, questions?
How do books derive, like, are they written down, or are they like a developmental stage, or how they're raised, like, the child?
Well, your book talks about it, but all the things we talked about, hereditary and this growth, this health assessment and well-care child is sort of one that you gotta take in. It brings back a lot of things that we talked about, in terms of, assessing a child. But it will come back throughout the course. In other words, different kinds of things that we focus on in each age group and each system that has problems. But when we do an assessment, basically you have to understand where a kid comes from. These are the things that may impact them. Obviously, they're environmental, but obviously lower income versus higher income, where the child's getting an environment, what their education level is, what kinds of discrepancies. The thing that you want to remember most is that there's 3 levels that well, there are actually 4 levels of prevention. We talk about primary care, which it has a big concept called anticipatory guidance. I heard Justine use this a lot. But anticipatory guidance is educating families and parents as to what to expect so that they can make the environment the most stimulating and safe for their child. And so primary is prevention, primary prevention. Secondary is looking at people who are at risk for certain types of diseases and getting an action plan in place for the intervention to prevent some types of development. Here I would say a secondary level of prevention might be that you've identified asthma as being part of the child's risk, and so you teach parents and you create an environment, an action plan for the child to prevent the development of let's say, status asthmatic situation. And then tertiary is the child has been identified with a problem, and so we're trying to do our best to prevent complications. I might think of the kid with acute diabetic juvenile onset diabetes. And so here we have complications that can occur related to swings in their blood sugar, ulcers, hypertension, obesity, and so we put things into plans so that these kids can have the ultimate care that they can to deal with the diabetes. And then there's quaternary care, which is basically the children's hospital, where we have both research and other state-of-the-art programs that might try things that haven't been tried before, that have had success, that could help a child with their illness. So you can think of the NIH as a quaternary care example, where investigative protocols for certain kinds of cancers are being used with success, right? Okay, so those are important. So what do nurses do? Education, pretty much. We make sure parents are aware of prevention clinics, services. So if we're in the inner city, we might be doing things like making sure parents know where the health clinics are, where the WIC office is, where they can go to get urgent care, those kinds of things. We often serve as great case managers. Our case managers walk on air to me. They get kids who are very complicated out into the community, making sure they follow up and have access to certain kinds of things. We are always on the forefront of implementing community-based kinds of programs for kids, and we sit on a lot of high boards that advocate for these kinds of services for kids. So it's not unusual that you see nurses in a lot of health policy positions. So immunizations has always been a challenge. There is a foundation that has made it its mission to make sure every child in the world is immunized. You know what the name of that foundation is?
Oh, Bill Gates.
The Bill and Melinda Gates Foundation that is their primary initial purpose, was to immunize every child in the world. You know what the immunization rate in the world is? It's about 85 to 89%. It was less before they put millions of dollars into programs to immunize children all over the world. It's expensive. Some areas don't have it. We know that certain outbreaks of certain kinds of preventable illnesses that have immunizations with them have devastation. And one of the biggest challenges we've had recently is the measles, mumps, and rubella vaccine has been disputed as or aligned with autism. There's absolutely no data to support any of that. But it continues to be argued and thought about. So these are kinds of things that has two things to it, a history and a physical exam. Famous physicians, DeGowan and DeGowan, basically said that if you do a good history, you will have done 90% of your exam. So it's all in the questions that you ask, and it happens all the time that we don't get the correct answers to the questions. But good health history is going to basically dictate what direction you go, whether it's for an acute visit or a routine visit. I just want to go back on reasons of immunizations and point out a few things in your book. Some of the things about immunizations is, hold on, I'll find it. I'll find it. I want you to focus on, because it's just reading a list of different immunizations, but I want you to focus on reactions. I want you to focus on contraindications. It talks a little bit about the MMR and fever and what it means with immunization. It just means your immune status is being kicked in, but we'll get to it. Okay, so when we talk about health history, there is a basic history that everybody gets in terms of the format that's used by the clinic or the hospital that you're working with, and that basically is based on a bunch of questions that cover one, present illness, history of present illness, past medical history, review of all the symptoms or the systems, and that basically gives you a comprehensive picture of why the kid is visiting. So if you have a kid who has a respiratory problem, so we're not going to focus on, their musculoskeletal system. But the history basically is going to dictate where you go. What we tend to end up having problems with is that we jump to conclusions and we miss a lot of questions, and then we end up with an incomplete history. So again, the forms are basically dictated by the place that you work. Some of the questions that tend to get missed a lot of times are cultural questions, and that might have impact on how a child is then treated, and how a health history is obtained. So if you're in a rush, you're probably not going to get all the information that you wish you got. So again, your book talks about different ways to approach people. Components of a comprehensive history is listed for you here. One of the things you don't see in an adult exam is the growth and development history. So we want to know, for example, in an annual physical exam for a 2-year-old, if they're developmentally on track. Are they walking, talking, all those things that we would include. And so, again, cultural assessments are also sort of drive sometimes things that are being done. In addition, different ways of obtaining a history, not only your style, but for example, with adolescents, we want to get a history maybe with the parent present for some of it, and then when the parent is not present, because we want to give the adolescent the confidentiality that we want to ask them specific questions that maybe they don't want their parents to know. I will say that with a caveat. And the guideline you want to always use is that if you learn something from a history, particularly an adolescent, that puts the adolescent at risk and or others, you're bound by moral principle to bring that to somebody's attention. Doesn't mean you call the police, doesn't mean that you call in the, whatever, but you need to at least report to your supervisor, all right? So any person that gives you information that puts them at risk for their safety and the risk of others. Okay, so remember that there's questionnaires that can get a lot of information, and there's the direct health history, and that's the way a lot of people are going these days. When we interview adolescents, we look at the HEADS as an acronym. We talk about it's a different type of exam because it focuses most importantly on drugs, depression, suicide, and sexual history, which we probably would not ask a 2-year-old, right? But the adolescent, we include that as part of the exam. So the HEADS exam is the acronym for that. It's listed for you there. So here are all the components that I mentioned for you. Again, knowing why the purpose of the visit is really important. Sometimes people will come in and they'll say, well, he has a cold, but I want to talk to you annual exam, of course, all bets are off. So again, sort of this is the thing here. So the physical exam includes obviously your vital signs, measurements for height and weight, and a good sort of look at the child from head to toe. We recently had a 14-year-old come in who had acute onset of abdominal pain for 24 hours, went to another hospital. He was so sick that he had to come to the intensive care unit because he couldn't keep his blood pressure up. I came in to examine the patient, and I said, okay, I'm going to leave so you can put on a gown. He didn't want to take off his pants. Well, adolescent, why would you want to take off your pants, right? So I said, well, it's really important, just for a short period of time, you need to look at your body because you have abdominal pain. So on my abdominal exam, I noticed there's a scratch on his right side where he's having the pain. I said, do you think this was causing it, this scratch here? What happened? He goes, oh, it hurt so bad last night I was scratching myself. So he goes on to get sicker and sicker. The end of the story is that he'd been playing around with a gun with his friend the day before, and that was a gunshot wound, and there was a bullet inside his intestine. Did I ask him several times, what had he been doing in the last 24 hours? He brought on this acute pain. The mother was standing right next to him. And he was sick, and so we're not going to ask the parent to leave, but should I put two and two together? You want to drop his pants? No, and he did. Finally, I said, I need to examine you because this is part of where the pain's coming from. So even after seeing that, because I said, someone get an abdominal x-ray, and I was signing off, so I found out the next day that got an abdominal x-ray and there was this bullet. So somebody went in and said, could you tell me if you had a gunshot wound recently? No. No, I didn't. What? What are you talking about? A bullet in your abdomen. Oh, and then 15 minutes later he goes, well, my friend and I were maybe playing with a BB gun. No, that's a caliber 9. That's pretty cool. Ended up lacerating his liver and landed inside his intestine. Wasn't appendicitis. All right, so you look at all the body systems. One of the things you want to look at overall right away is this a clean exam or a dirty exam? I mean, if the child is unkept because the younger child can't care for themselves, that should tell you something. When we talk about skin, we look at turgor. A lot of people talk about tenting, overused. So, a kid who's dehydrated is going to show you a lot more things other than, skin tenting. You're not going to make the diagnosis off of that. Remember that when taking vital signs, your blood pressure cuff must be the proper size or you're going to get an erroneous number. The smaller the cuff, inappropriate size, the higher the number, which could give you a hypertensive patient and you didn't even know it. Remember that when you watch breathing and you listen and you feel for a pulse, it's for a full minute each. And remember your developmental kinds of issues. When we look at the face and the nose, remember that some kids can have huge tonsils. So we want to look at those, look inside the mouth and look at them. You don't want to gag a kid in the beginning of a physical exam because that will deteriorate the rest of your exam. Remember that lung sounds have normal sounds, which are vesicular and bronchovesicular. Those are normal sounds. You've probably been hammered into your head about rales and bronchi. But there are normal sounds. They're clear. Vesicular and bronchovesicular. As far as cardiovascular is concerned, many kids have hearts very close to their chest. So it's a very hyperdynamic kind of experience. So you may think you hear a murmur. Best thing I can tell you to do is listen to your own heart before you go in and listen to the kid's heart. Yes, little hearts beat fast, but you want to know what a normal heart sounds like and then listen to the kid's heart, okay? When you're using your stethoscope, and by the way, a stethoscope is now considered an antique. You shouldn't be using it. You should be using other things like phones. I can look at whatever. I still use a stethoscope. When you're using your stethoscope, remember to make sure it's clean. 2, do not blow on it in front of a parent with your breath and then put it on the kid. This sort of flies in the face of any infection control that could possibly be created, all right? Do you want to rub it in your hands gently before you go in? Well, sure, but that's not exactly the best infection control either. Do you want to rub it on a surface that's clean? Sure. The point is, don't put a cold stethoscope on the kid because that contributes to them being pain. Remember that abdomens don't get palpated first, they get auscultated first. And this is helpful in kids. You've got to listen for a good 2 minutes for vowel sounds, all right? All right. When we talk about lymph system, a lot of kids will have painful lymph nodes. usually one isolated. You can have a growing lymph node, have a respiratory infection. Look at the genitalia for cleanliness and discharge, just like you would an adult. Remember, often little boys are not circumcised, so you have to gently retract the foreskin. If that's what you're doing. I mean, you don't have to be doing foreskin retraction if you have a kid with respiratory distress. Remember that kids who are newborns, are going to see a newborn exam, and ortolani is a maneuver where we hear the hip pop into place, whereas the Barlow's, we feel it dislocate. So you hear the ortolani on the hips, you feel the Barlow. And the ortolani is popping back in, that's what you hear. The Barlow is feeling it dislocate. We use that for hip dysplasia in newborns. There's pictures in the book. Now, let's talk about neonatal reflexes. Kids will have neonatal reflexes up to 6 to 8 months of age, and they'll lose them as the neural system starts to mature with the muscular system. Remember that on physical exam, kids who are getting neonatal reflexes, you should look at the pages in your book, and you should sort of learn them. I like to just sort of talk about a lot of great diagrams in this thing in terms of listening for heart sounds. If you ever noticed on page, that's 282, if you ever wondered where put a Foley, page 287 has exactly where you should go. So whenever you put a Foley in a little kid, a girl, because boys should be pretty obvious, you'll notice that the anatomy is very helpful to know ahead of time, instead of just, I hope I get the right Foley, okay? The ortolani and the Barlow's is listed for you, looking for alignment. Okay, so neonatal reflexes. So Babinski is the foot, outside of the foot. We often hold newborns or infants up to see if they can walk. We call that stepping. When we talk about the moral, we basically hold the kid up and then hold the hands and then let them start to drop rapidly and grab them. And we look for the neck to drop down or come back up and try to right itself. So the moral. We talk about palm of grass. Every child should grab your finger. The rooting is when you stroke the side of the mouth and you see them sucking toward it. The startle is when the child's laying on their back, you clap your hands and they throw everything out. So that's the startle, right? Okay. Again, the sucking, and then the parachute is when you hold the child prone underneath and they should reflexively put their arms out. And then the tonic neck is when you clap on one side and you stimulate the child. They tend to want to go that direction, so we want to extend it. All those are neonatal reflexes. They should disappear between 6 to 8 months. If they don't, the child will have developmental decay. So we want to measure the head. Basically, it shows you a great picture above the ears to get a head circumference, and you do that routinely. When you're auscultating the heart, there's a small space, people. And when you think about auscultating the lungs, there's a lot of bone and a lot of scapula. So the best place I always tell students to listen is under the arms, because presumably you have more open rib space. It's not all crammed together with the sternum, all right? And you can hear some pretty decent breath sounds back here, all right? As far as the heart is concerned, look for your PMI, your fourth intercostal clavicular line. Typically it's pretty easy. It's a little higher than you think than an adult. And then listen for a full minute, okay? There are other things that we do other than to listen to the heart and the lungs. We look at capillary refill, and I guess that would have to be my sixth vital sign. SATs are my fifth. My sixth is cap refill time. So take your finger, your left index finger, all right down, pinch it with your right, and watch how fast the refill comes back. I'm hoping that it's less than 3 seconds. In kids, it's less than 2 seconds. So we basically use that as an indicator of perfusion. Talk about pulses, but cap refill time is perfusion. That basically tells us how well a child is perfusing from their heart. So cap refill time is always considered best less than 2 seconds. You can often see by a foot, take the foot and press down with your thumb. Kids who are dehydrated, that print will stay there for a good 3 to 5 seconds. And whenever people sign out to me and they say cap refill time is 4 to 5 seconds, I'm rather concerned. We don't have good perfusion, right? Okay, I don't know, I don't assess a lot of smell in children, it's crucial, but, obviously smell is number one. I always like to tell everybody to just group them together. So if you think about it, 2 is your vision, 2, 3, 4, and 6 have to do with vision and eye movement. So 2, 3, 4, and 6 are all about the eyes, okay? 5 and 7 have to do with how a kid moves his face. So 5 basically is the movement of the jaws, and 7 is basically, does the kid have bilaterally equal movements to smile or something like that. 8 is your hearing, so 1 is your smell, 8 is your hear, everything else in between. For me, it's all about 10, the vagus. How can somebody gag or swallow? So it's all about 9. All about 10. And 9 just helps out 10. 9 helps out 10. Swallowing 10. 11 and 12 basically, 11 is about the shoulders, and 12 basically helps out 10. So 9 and 12 help out 10. 11 is about the shoulders. So it's just testing to see if that bilateral movement in the nerves. Do I do cranial movement? Do I do testing of cranial nerves? I can't think of the last time I did cranial nerves. Okay, immunizations, starting on page 299. You should read about immunizations. Why? Because we give a lot of immunizations in the first year of life. That's why we bring kids back, not to see how they're growing, but to cause them pain and give them immunizations. You should be able to tell me what immunizations are given in the first year of life, and you don't get it here, so what you do is you go to Google immunizations, and it brings up the chart. Why don't you think it's in your book? Is that an oversight of the book? Why don't you think they put an immunization table?
Because of the different changes? Or?
It does change every year. We have a change to the immunization, and it's updated every year. Actually, it changes every 6 months. We do different kinds of things. And so we have immunizations for the kid who starts at birth, then we have catch-up immunizations, and then we have new immunizations. So you should have a basic idea for this exam what immunizations are given to a child under the age of 1. I can help you out a little bit. I can tell you we immunize for hepatitis A and B, we immunize for diphtheria, pertussis, tetanus, and pertussis is whooping cough, and polio. So the DPT, or the DTaP, is diphtheria, pertussis, tetanus, and typical polio. We immunize for chickenpox. We immunize for monopolis influenza, the Hib vaccine. The Hib vaccine has been in use for about 25 years. It's almost eradicated meningitis in children. That's why we don't see it anymore. The chickenpox vaccine is about 25 years old, and we don't see chickenpox in children. Well, we'll see some. The measles, mumps, and rubella, the MMR, eradicates measles, mumps, and rubella. Remember that the immunizations are basically to prevent serious side effects of what these diseases can cause. Many of them are boosted through the first 4 years of life. I don't expect you to really know all of that, but I do expect you to know what immunizations are given in the first year of life. They're all typically given in a muscle. Typically in a kid, we used to say that the anterior lateral medialis is the best shot, but typically you'll see kids getting in the deltoid after a year of life. Now there are reactions because what do immunizations do? They build your immune system, right? So your immune system goes into high drive to create antibodies to the little bit of a vaccine that we give, right? And so what that does is that's a B cell kind of job, meaning that the antibodies get in, the vaccine gets into your bloodstream, your B cells will basically make antibodies to that vaccine that you got, and then they'll go live in the lymph system for a while, the thymus, wherever. And when you get exposed to something again, your immune system will come out and protect you with the antibodies. Now you could say, why don't we get smallpox and why don't we get tuberculosis vaccines? Because we have enough immunity to fight those off. In fact, we eradicated smallpox. So we have enough immunes in our body, antibodies, that we can be exposed to it and do quite well. Thank you very much. why people in Africa do not get sick with the Zika virus anymore, because they developed antibodies. But for the period of time that they developed it, they were sort of like the FDA drug testing by getting mosquito bites. They developed their antibodies. Instead of getting the vaccine, they got the real thing, all right? Now, there are people with the Ebola virus, I mentioned this, we would like to, those people that they put in, got their blood work, got exposed to Ebola but didn't get it, those people should be charging a lot of money because we based the vaccine off the antibodies they developed. They developed their own antibodies and were able to fight off the Ebola virus and survive. It's pretty impressive. All right. Is that enough? Enough? What you want to review? Like the exam. Okay, any questions about physical exam? And that will be coming back and again and again.